Hello, today we will talk on hypotension and mean arterial pressure. Sometimes in our clinical world, we find that there are low pressure patients. Sometimes we record the pressure 90 by 60 or 80 by 50 or 80 by 60 and so on. And invariably we become confused that this pressure is hypotensive or not. So there should be a clear conception, and for this purpose, to make you clear about the hypotension, today's short video, when we find that mean arterial pressure is more than 65 mm of mercury, then it should not be called as hypotensive, as because to maintain tissue perfusion, mean arterial pressure should be more than 65 mm of mercury, most importantly to maintain the renal perfusion. But in some cases, especially those patients with hypertension, mean arterial pressure should be around 80. So when mean arterial pressure goes below 65, only then we can call it the hypotension. Say you have found that the patient's blood pressure is 90 by 60. So is it hypotension? Or you may find that blood pressure is 80 by 60. Is it hypotension? Or 70 by 60. Is it hypotension? Which one is hypotension? So to make a clear conception, we should know the mean arterial pressure. Now, why does the mean arterial pressure is so important? As because mean arterial pressure is important to maintain the renal perfusion, and if renal perfusion is impaired or decreased, then patient will present with oliguria. So oliguria is the first and early sign of poor renal perfusion, that means hypotension. Now come to the point, what is mean arterial pressure? Mean arterial pressure equal to diastolic pressure and 1/3 of pulse pressure. Diastolic pressure plus 1/3 of pulse pressure. What is pulse pressure? Pulse pressure is equal to systolic blood pressure minus diastolic blood pressure. If patient's recording is 90 by 60, so is it hypotension? Or if patient's recording is 80 by 60, say, so is it hypotension? Okay, calculate here mean arterial pressure equal to diastolic pressure. So here diastolic pressure is 60 plus 1/3 of pulse pressure, that means systolic blood pressure minus diastolic pressure. Here systolic blood pressure is 90 minus 60. So 60 plus 1/3 into 30 equal to 60 plus 10 equal to 70. So 70 is more than 65. So this is not hypotension. Okay, look at here, mean arterial pressure equal to diastolic pressure plus something else, that is 1/3 of pulse pressure. So question may arise, why does diastolic pressure is so important? Because in cardiac cycle, what do you mean by cardiac cycle? Diastole plus systole. The cardiac cycle extend for 0.8 second. 0.8 second. In the cardiac cycle, the heart spends its 2/3 of total cycle time in diastole, that is around 0.5 second, and only 1/3 time pass in the systolic phase, that means 0.3. So as the heart passes its maximum time in the diastole, so the pressure maintained in the diastolic phase should be emphasized. So diastolic pressure represents mean arterial pressure more accurately. Very important question. So if mean arterial pressure less than 65 mm of mercury, then you can call it hypotension. Now the question is the patient in the state of shock? Hypotension invariably leads to shock. So every hypotensive patient are not in the shock. Mind it, every hypotensive patient are not in the shock, and there may be some type of shock without hypotension. What does it mean? Usually, hypotensive patient leads to shock. Okay, but there are some shock without hypotension. Now, if you find that a patient is hypotensive, and you should take the decision, is the hypotensive patient is going to develop shock or already in the state of shock? Very important clinical question it is. And another question is, there are some sort of shock without any sign of hypotension. Actually, hypotensive shock means cardiogenic shock due to heart failure, like. And this case, patient develops shock, and before developing shock, patient goes through the state of hypotension. On the other hand, there are some type of shock where you find that the pressure is quite normal, such as neurogenic shock or spinal shock, where the pressure will be quite normal. So you have to think with your sound brain while you are working in your clinical ward. Now, the question is, patient is hypotensive. We have decided that patient is hypotensive because mean arterial pressure is less than 65. Now the question is, patient is in the state of shock or not? So to decide about the shock, at first we should know what is shock. Shock is just tissue hypoperfusion, and here shock means cardiogenic shock, a hypotensive cardiogenic shock, and this shock is due to tissue hypoxia. What do you mean by tissue hypoxia? Tissue hypoxia means oxygen delivery, decreased oxygen delivery at tissue level. So the question should arise here, how does oxygen delivery is maintained in the tissue level? The oxygen delivery at the tissue level is maintained by the oxygen content of the blood. The new term is oxygen content of the blood. Oxygen content of the blood. Now we should have clear conception about the calculation or measurement of oxygen content of the blood, or the question should be like this: how does oxygen content of the blood maintain? This is the equation of oxygen content of blood. Oxygen content of the blood equal to hemoglobin level into oxygen saturation of the blood. If hemoglobin level is decreased, that is called anemia. So when patient is anemic, that is hemoglobin level is decreased, that means patient's oxygen content of the blood is decreased. That means patient have increased risk to develop tissue hypoxia, that means shock. And another parameter is oxygen saturation. Oxygen saturation is related with the oxygen content of the blood. Now, what do we mean by oxygen saturation? To understand the oxygen saturation, please look at here. This is your alveoli and this is your pulmonary bed. Deoxygenated blood enter and become oxygenated here. Oxygenated hemoglobin exit from here. So oxygenation of blood occurs in the pulmonary bed, and this oxygenation or saturation is maintained by circulation. So if circulation is maintained through the pulmonary bed, the oxygenation or oxygen saturation will be maintained. And if circulation is not maintained, oxygen saturation will not be maintained. Very easy. So the new term is circulation, blood circulation through the pulmonary bed. How does this circulation maintain through the pulmonary bed? The answer is cardiac output. The cardiac output maintain the circulation through the pulmonary bed. Now the question is, what is cardiac output? So here, this is the cardiac output equation. Very simple. What do you mean by cardiac output? Cardiac output equal to heart rate into stroke volume. Heart rate and stroke volume maintain the cardiac output, and this cardiac output maintain the oxygenation or oxygen saturation. Okay. Now what is stroke volume? Stroke volume. The stroke volume depends on the preload, that is the load on the ventricle before the ventricular systole. That means load at the end of the diastole. So it is called end diastolic volume, the number one parameter on which the stroke volume depends, the preload. And number two, the cardiac contractility. If heart muscle contract forcefully or heavily, the stroke volume will be increased to certain limit of course, and if preload is maintained, the stroke volume will be maintained. So on this two factor, the stroke volume depends. So as a whole, if cardiac contractility decrease, stroke volume will be decrease. If cardiac contractility is maintained well and good, then stroke volume will be maintained. If preload decrease, stroke volume will be decrease. If preload increase up to a certain limit, then stroke volume will be maintained and increase. So everything here, the stroke volume if maintained, oxygen saturation will be maintained. That means blood circulation through the pulmonary bed will be maintained. And if oxygen saturation is maintained, the oxygen content of the blood will be maintained. And if oxygen content of the blood is maintained, then oxygen delivery to the tissue will be maintained. So all the parameter here, if goes down, then oxygen delivery to the tissue will be down, so patient will develop tissue hypoxia. So to manage a patient with hypotension and shock, what you should do? Number one, to optimize the hemoglobin level. If you see that patient is moderate to severely anemic, then you should go for blood transfusion. Number one. And number two, and if you see that the cardiac output is not maintained, then you should take the measures to maintain the cardiac output by increasing the contractility and by increasing the preload. Okay, and sometimes if patient have congestive cardiac failure where preload is very high, as so high that heart cannot take the blood, in that case you may give the diuretics to decrease preload and to optimize the preload within the physiological limit. So for summary, if you find any patient in your clinical ward that is patient with mean arterial pressure less than 65, so then you think this is a patient with hypotension. The next question, is the patient in the state of shock? To understand the shock, you should know what is shock. Shock means tissue hypoxia, and tissue hypoxia is due to decreased tissue oxygen delivery. The oxygen delivery is decreased due to decreased oxygen content, and decreased oxygen content is due to anemia and decreased oxygen saturation, and this oxygen saturation may be decreased due to decreased stroke volume, and decreased stroke volume is due to decreased preload or decreased contractility of the heart muscle. So think yourself wisely in your ward and give your patient the best service. Thank you very much.